Hello, good afternoon, everyone. Respected faculty, my seniors, as well as my co-students. Thank you so much, first of all, for coming. I will be introducing, beginning the clinical backgrounds of today. The participating departments we have is ophthalmology, dermatology, and otolaryngology. From dermatology, we have Dr. Japu, senior resident, and from ophthalmology, we have me, junior resident, Dr. Ramit. And from ENT side, we have Dr. Rameshwaran, senior resident. And our faculty who will be coordinating is Dr. Saurabh Verma from ophthalmology, Dr. Vishal Gupta sir from dermatology, and Dr. Sujita ma'am from ENT. So the topic for today's case report is uncool dystonia, but for the sake of this presentation, let's just call it uncool dystonia. Where a skin scar meets an ocular story, and we'll have to hear the tale. This is a proof that in medicine, one line can blur several specialties. So, 10.5-year-old boy presents to the RTC OPD with a painless loss of vision in both eyes, but left way worse than the right, which he noticed around 1 week ago. He also had bilateral frontoparietal skin depressions, which I will be showing subsequently in the next slide, which had been present for the last 3 years, but not before that. The mother also gave a history of bilateral hearing loss, and the child also had a hearing aid incident. He also had a past history of delayed language milestones. Apart from that, there's no significant family history, no history of neurological abnormalities. So these are the photographs of the child. As you can see, the bilateral frontoparietal linear skin depressions with associated loss of subcutis are present, way more on the right side than on the left side. Over here, they are also associated with alopecia in that area on the scalp, as well as around the eyebrows and eyelashes. The left side is less prominent. Here we see the loss of eyebrows and eyelashes in the same line of the lesion. In the ocular examination, the best corrected visual acuity in the left eye was 6/18, in the right eye was 6/6, with a normal intraocular pressure, normally active pupils, normal extraocular motility. The slit lamp findings were also within normal limits, no AC cells were flared, no kinetic precipitates. On a dilated fundus examination, I will be coming to the findings in the next slide. So this is the right eye. This is a wide field of the CT, the right eye. As we can see, the media was clear, a few oral cells were present, an average sized vertical disc with a Coppers ratio of 0.3:1 was present. Neovascularization at the disc can be seen over here and here. FRS chart, A ratio is 2:3 in the central area. 360-degree peripherally sclerosed arteries and veins can be noticed here. A large FBP can also be noticed supratemporally. Here, the arterial sclerosis, the FBP, and then some LVEs were also present, not very visible on the upper CT, but much more seen in the FBP. This is just to see the segmental arterial sclerosis, along with venous sclerosis. Now, this is an opto CT of the left eye. The left eye showed a media haze due to the vitreous hemorrhage. RL cells and RBCs were also present. Now, here, the disc was hazily seen. A large nasal, supranasal fibrovascular proliferation with TRD can be seen, FR could not be appreciated. Here also 360-degree sclerosed arteries and veins are present, but not as appreciated on this CT. Large FPP, BH, and also a small inferotemporal FPP was present. This is a macular OCT of the same child. As we see, a mild blunted foveal contour can be appreciated, but no macular edema in both the eyes. Now, this is a temporal sequence FFA of the given child's right eye. Now, we are beginning directly with the arterial phase, going on to the venous, arteriovenous and the venous phase, and then the late phase. As we can see, this child has sclerosed arteries, so there is an area of non-perfusion in the periphery. And we can also appreciate peripheral ischemia. Then, as we go on further, we can see the NVD and the NVE much more clearly with late leakage of the fluorescent light. So here is the NVE which I tried to show. Then you have NVD. Here also a very minute detail we noticed was small aneurysms at the junction of vascular and avascular retina, then MVEs and MVD. In the temporal sequence of FFA of the left eye, we had a large supranasal FPP which was present, so a lot of leakage of dye over here. However, we have blocked fluorescence in the rest of the area of the retina because of the presence of the vitreous matter. The child already had previous imaging done. He had a CE-MRI, he had an HRCT. The CE-MRI had some T2 hyperintensities in the frontoparietal region bilaterally, which was suggestive of maybe ischemic changes, but not much clinical significance. Based on the skin lesions, a provisional diagnosis of bilateral uncooked sabre was made because of the resemblance of the strike of sword. So, appropriate referrals were sent to our departments of dermatology and ENT. We also sent some blood workup of the child. Among significant findings was that CBC showed some eosinophilia, not very much, but still present. And the rheumatoid factor was positive, but still, again, not very much. Then dermatology did carry out a skin bunch biopsy, and this is just the histopath report, which confirms our suspected diagnosis. This is just an ophthalmology of the right eye. This was done after we did a laser of the avascular retina. In the left eye, the laser was incomplete due to age. Now I'll invite my faculty to go ahead with the discussion. Okay, first I'd like to invite the note for the dermatology.
Good afternoon, all. I am Dr. Chaknoor, Senior Resident in the Department of Dermatology and Venereology. So we received this case around 2 weeks ago, 10.5-year-old male with total duration of the disease since past 3 years. He had an insidious onset of the disease. He complained of a linear depression involving the bilateral parietal and portal scalp. It was associated with hair loss overlying the plaque, and he also had associated ocular as well as hearing abnormalities. He did not have any neurological abnormalities, and the cutaneous lesions were not progressive since the past 6 months. So on examination, we noticed that there was an indurated plaque, a linear plaque, extending from the parietal region on bilateral sides, extending towards the lateral eyebrows, also involving the upper eyelid as well as the eyelashes. It had a faint hyperpigmentation with epidermal atrophy involving the bilateral temples of the forehead, and it was associated with scarring alopecia involving the scalp, eyebrows, and eyelashes, overlining that plaque. So we clinically suspected the diagnosis of bilateral and sabre or head and neck variant of localized scleroderma. A biopsy was undertaken which showed unremarkable epidermis. The papillary dermis showed focal sclerosis. There was mild perivascular lymphohistiocytic infiltrate. Subcutis, however, unfortunately was not included in the tissue. With this clinical as well as the histological findings, we made the final diagnosis of bilateral and sabre. So morphia is a chronic inflammatory and fibrosing disorder of the skin and underlying tissues. It can extend beyond the skin and the subcutis, involving the muscle, fascia, bone, as well as occasionally the brain. The incidence of morphia is 4 to 27 per million per year, so it's a rather rare disease. And around half of the cases begin in childhood. Linear morphia represents around 20% of the morphia cases. The extracutaneous manifestations are seen in around 20 to 75% of the patients, more so in pediatric cases. Morphia has been classified into various classifications by different authors, but by and large, they all include the following categories: that is, the limited type of morphia, the generalized type, the linear type, as well as the deep type. Here we are concerned about the linear type of morphia, which has two variants: trunk or limb variant and head and neck variant. In the head and neck variants, there are morphia include this sabre, and the other is a progressive hemifacial atrophy, which is also known as Perry-Romberg syndrome. Coming to the pathogenesis, the disease evolves in 3 phases. The first is the inflammatory phase, the second is the sclerotic phase, and the third and the last is the atrophic phase, which is also called the burned out phase. So, with the environmental triggers in a genetically predisposed individual, it leads to the increase in the T cell population, which further leads to the damage in the endothelial cell lining, leading to the secretion of the adhesion molecules, including the VCAM1, ECadherin, and ICAM1. It increases the population of the Th1 and Th17 cells, and also their cytokines, including the TGF beta, CXCL9, 10, IL-23, etc. In the sterotic phase, a switch occurs from the Th1 cell population to the Th2 cell population, and the cytokines secreted here are IL-4, IL-5, 6, 10, IF and gamma, as well as the TGF beta. It leads to the increase in the fibroblast activation, which leads to the formation of collagen and fibrosis. In the atrophic phase, the inflammatory milieu dies down. The fibroblasts also get inactivated, but the sclerosis and the fibrosis remains. It has been found that the active phase of morphia shows significantly increased genes in the KRAS pathways, the JAK-STAT pathways, and the TNF alpha signaling pathways. That is why now the JAK inhibitors like tofacitinib are also being used and successfully used in cases of morphia. And recently, CXCL9, which is secreted by keratinocytes as well as the T cells, has been validated as a biomarker of morphia disease activity. It correlates well with the active disease, the activity validated scores, and also the increase in CXCL9 predicts the reactivation of morphia activity in up to 70% patients within 9 months of the increase in CXCL9. Coming to the clinical features, the different phases of the disease present differently clinically. The first, in inflammatory phase, it has a slow and insidious onset. The patient might even not notice the lesion. It has a bruise-like appearance with mild faint erythema, edema, and it may have ill-defined borders. The next stage is the sterotic phase, which will have a central sclerotic white area. It may be depressed or indurated, and it is surrounded by an erythematous to vivacious ring, which is also called the lilac ring. It reflects the ongoing active disease. Then comes the atrophic phase, which may occur months to years later on. As the lesions become atrophic, there will be depression. The upper epidermis may appear thin, and they are usually hyperpigmented more commonly than hypopigmented. The other clinical features as seen in our patient include alopecia, which is predominantly the scarring type of alopecia, which will be present in the areas of the lesion, as seen here in the scalp, the eyebrows, and the eyelashes. It can also lead to asymmetry of the facial features, indentation of the skull. Now, head and neck variants include Encouptis sabre and the progressive hemifacial atrophy, also called the Perry-Romberg syndrome. There are a few differences in the two. In Encouptis sabre, there is a predominant skin induration and thickening. There can be a visible vivacious hue to the lesion, or it may be hyperpigmented, hypopigmented, and on palpation we can feel the indurated skin. While in progressive hemifacial atrophy, the skin is not involved, the underlying tissues, including the muscle, fascia, bone, are usually involved. In Encouptis sabre, it usually starts from the forehead and the scalp, and it does not extend beyond the eyebrows. Whereas on the other hand, the progressive hemifacial atrophy, it usually starts from the cheek and nose region, and subsequently involves the entire one half of the face, also including the mandible. The intracranial involvement is seen in both. And there is a popular belief by many authors that Encouptis sabre may eventually progress to lead to progressive hemifacial atrophy, where the skin involvement may not be marked, and the lesion may extend beyond the eyebrows to involve the lower half of the face, including the mandible. Encouptis sabre usually occurs in the first or second decades, and the active stage lasts for 2 to 5 years. It is associated with many extracutaneous abnormalities, including the CNS abnormalities, which is seen in around 30% of patients with Encouptis sabre. The most common manifestations include headache, migraine, epilepsy, while the lesser common ones include cranial nerve palsy, the neuropsychiatric problems, vascular malformations, and CNS vasculitis. These neurological manifestations are largely unrelated to the activity and severity of the cutaneous disease. And many patients who do not have any symptoms may have significant CNS abnormalities on imaging. The radiological findings may include bone thinning, cerebral atrophy, white matter lesions, meningocortical changes, and even vascular changes. Then the ocular involvement is in and around 2 to 8% of the patients. The most common ones are epistylitis, anterior uveitis, keratitis, amongst the others. And it is to be noted that in 25% of the cases, ophthalmological findings may be unrelated to the size of the skin lesions. Therefore, both the eyes should be examined equally, and a patient should have ophthalmological assessment 6 monthly in craniofacial morphia for the first 4 years. The complaints of hearing loss, the reports are fast. There are only 1 or 2 case reports on hearing loss associated with improved sabre, and it has been hypothesized that it could be because the differentiation of ectodermal progenitor cells, which differentiate into keratinocytes as well as the vestibulocochlear nerve, may be relevant to improve sabre. The other organ involvement is rare. It includes vascular involvement like vasculitis, DVT, Raynaud's phenomenon, GI involvement in the form of GERD, and arthritis. So once we suspect a patient of linear morphia, we have to measure the activity of the disease by the low stat score. We should do a biopsy of the lesion. The radiological imaging should be done, especially in the cases of head and neck variant of linear morphia, as well as in cases of deep morphia. And serological investigations should also be done, which I will tell about in shortly. The low stat score, it stands for localized scleroderma cutaneous assessment tool. It includes the activity index as well as the damage index. And we have to ask the patients if the patient is developing any new lesion, the previous lesions are enlarging, if the patient has any erythema, and the skin indurations we have to assess for the activity. For the damage, we have to assess the dermal atrophy, subcutaneous atrophy, both of which may present as depression, and this pigmentation, which may be in the form of hypo or hyperpigmentation. The score of 0 to 4 refers to mild disease, 5 to 12 is moderate disease, and 13 or more than 13 is severe disease. Low stat score can especially be used in case of follow-up of the patient to see if the disease is progressing or to see if the disease has any improvement with treatment. For histology, ideally an elliptical incision should be made through the vitreous edge into the sclerotic center, and the subcutis should also be included. The histological findings will be different in the early inflammatory stage and the late atrophic stage. In the early stage, along with the thickened collagen bundles in the dermis, there will be dense perivascular and periadnexal inflammatory infiltrates, while in the later stages, there will be highly packed sclerosed eosinophilic collagen bundles, but the inflammation will be minimal and the adnexal structures will be pushed up because of the fibrosis, and there will be loss of fat surrounding these adnexal structures. If the subcutis is also involved, it presents with septal panniculitis, and we refer to the photo of the histology as a cookie cutter image because the bilateral edges of the section, they appear very neatly cut. In serological investigations, ANA has been found to be positive in around 20 to 70% of patients. It is associated with severe and deeper disease and also with extracutaneous manifestations. Patients with positive ANA have 5 times greater odds of relapse after successful treatment at 5 years. Amongst the ENA, the anti-histone antibodies as well as the anti-ssDNA antibodies have been found to correlate to extensive disease and higher skin score. However, unlike the ANA positivity, these ENAs, they do not predict the increased risk of relapse. Other serological investigations include CK and LDH if muscle involvement is also suspected, ESR, CRP, and rheumatoid factor. The investigation of choice for brain imaging is the contrast enhanced brain MRI, and up to 20% of CNA lesions may progress and independently of the skin changes. So it has been recommended to repeat MRI every 1 to 2 years or if new symptoms develop by many European guidelines. Coming to the differentials, the first differential is the peridocular syndrome, that is the facial hemiatrophy. However, as we have already discussed, it will include the lower half of the face as well and the cutaneous inflammation, induration, the pigmentary changes will not be present. The other differentials include focal facial dermal dysplasia. It is a congenital disorder, has 4 types, and the patients characteristically have the foreset marks over the bilateral temples. There will be linear depressed lesion present on the bilateral temples. However, the patient will also have other dysmorphic facies, and it has been found to be associated with nystagmus, and hearing loss may occur secondary to dysplastic tears. But the patient will have a positive family history, and it will, the onset will be since birth. The other differences include Haber-Land syndrome, also called the encephalocraniocutaneous lipomatosis. It is a sporadic disease with mutations in the FGFR1 gene. The characteristic appearance is of lipomas in the scalp, and because they may present linearly on the scalp and are associated with the hair loss, they may appear similar to N. sabre. However, they have other characteristic findings like epibulbar dermoids and colpomas and intracranial lipomas as well. The other differential is the Delman syndrome. It is also a congenital disorder occurring sporadically, and the skin defects here, because of the dermal hyperplasia, may also resemble N. sabre. They may present linearly as an atrophic depressed scar. The other findings include orbital cysts, coloboma, and intracranial cysts. The other more commonly seen differentials include lupus paniculitis or lupus profundus, which may present linearly on the forehead in the paramedian area. But the patient's history, the examination, and the histological findings will help us to differentiate it from N. sabre. And the other close differential are the causes of acquired lactopathy as well. Coming to the prognosis, morphia has a protracted relapsing remitting course, and around 50% of patients have at least 50% softening by 4 years after diagnosis. However, relapse is frequent, especially in the generalized and the deep forms. Around 30% of patients report active disease even after 10 years of onset. And delays in the treatment initiation, even by as less as 3 months, is associated with longer disease activity, lower response rates to treatment, and higher relapse rates. Coming to treatment, for these superficial kinds of morphia, the topical treatment may suffice. The European Dermatological Forum guideline recommends the use of superpotent steroids for up to 4 weeks, or potent topical steroids for up to 3 months, with intermittent therapy beyond. The other topical options include tacrolimus, imiquimod, calcipotriol, etc. The other option is phototherapy, especially for the superficial variants of morphia. In the circumscribed or the generalized morphia, the phototherapy of choice is UVA1, but in case of unavailability of UVA1, PU1 and sterolin plus UVA may also be used. The response rates to UVA therapies range from 60 to 80%. However, the relapse occurs in almost half of the patients at 3 years follow-up. Now, systemic treatment is reserved for patients who have progressive disease despite using the topical agents or phototherapy, and in patients who have active disease with moderate to high morbidity risk. That is, in patients with deep morphia, generalized morphia, morphia affecting the head and neck area. The first line treatment option is the combination of steroids along with methotrexate. Steroids is administered in the form of pulses, either intravenously or in the form of oral healing pulse. The response rate to methotrexate plus steroid combination, it varies from 60 to 85%, and the relapse rates of 15% are noted at 2 years follow-up. The other immunosuppressants that have been successfully tried include mycophenolate, HCQS, tocilizumab, apremilast, and JAK inhibitors. So these are the pediatric rheumatology European Society guidelines of 2019, which state that after achieving the clinical improvement, methotrexate should be maintained for at least 12 months before tapering. This is the treatment algorithm which is provided in the same guidelines. If we notice that the disease is inactive on follow-ups and we see that with the photographic documentation the progression is not there, Certain interventions can also be undertaken, like dermal fillers, fat transfer, Botox, in case of linear depressions for cosmetic relief. So for this case, as the patient had non-progressive cutaneous disease since the past 6 months, we opted for active non-intervention with a close follow-up and photographic documentation to see if the disease progresses any further. Thank you. I'd like to call.
Good afternoon, everyone. We shall continue the ENT manifestations in case of localized scleroderma. Generally, the most common ear manifestation will be unilateral or bilateral sensory neural hearing loss, along with tinnitus or external auditory canal stenosis. And additionally, in nose, we can notice alar retractions due to skin fibrosis and any external deformity of nose, along with epistaxis and chronic rhinosinusitis. In throat, we can see microstomia, ankylostomia, xerostomia, along with hoarseness and anastomosis. In case of localized scleroderma, the special or unique feature is that it won't involve below the level of eyebrows. So most common findings will be only restricted to ear rather than nose and throat. So coming to hearing loss in case of scleroderma, the incidence is 40 to 50% in case of systemic scleroderma, but in case of localized scleroderma, it is very rare and only 4 to 5 cases have been reported. And considering pattern of involvement, mostly it is sensory neural hearing loss followed by mixed hearing loss, and then least common is conductive hearing loss, and mostly it will be bilateral then unilateral. So on our evaluation, we didn't find any malformed pinna. Both the pinnas are in normal shape and symmetry, and the EAC didn't have any stenosis. We didn't find any perforation in tympanic membrane, and on proceeding with the tuning fork test, Weber's, which was lateralized to the right side, and release was non-responsive on right side and positive on left side, and absolute bone conduction test was non-responsive, which indicates left side profound hearing loss, and facial nerve was found normal, and we didn't find any significant findings in nose and throat. On performing pure audiometry, we found right side profound hearing loss and moderate and mixed hearing loss on left side, which suggests that there is both conductive and neural pathology. On performing impedance audiometry, the left side A type of curve, which is normal, and we got CS type of curve on right side, which suggestive of eustachian tube dysfunction. On performing brainstem about response audiometry, we can notice that the blue color word, which is pretending to the left side, the fifth verb, which is a significant verb, which can be noted up to 40 decibels, and we can notice the morphology of waveforms starting from 90 dB. There is more peak to go, and when coming to 40 dB, the amplitude of the waveform is little less, it's decreased, and but there is a maintained interwave latency, which is the distance between wave 1 and wave 5. So considering delay and lower in amplitude, it is indirectly suggestive of cochlear involvement and early retrocochlear pathologies. On right side, which is indicated in red color, we didn't find any waveforms which suggest there is a profound hearing loss. So possible pathologies could be like vascular dysfunction and fibrosis, which lead to compromise of cochlear microcirculations. Since cochlea is end organ and the ischemic injury will lead to irreversible hearing loss, and there could be also fibrosis of muscular chain and eustachian tube, which will lead to conductive loss and further causes eustachian tube dysfunction. And there could be involvement of myelin sheath of auditory nerve, which can cause nerve dysfunctions. So current treatment what we provided to the child is hearing aid to the left ear, in which the child has a good response in lower frequencies and minimal response in high frequencies. This is the aided audiogram which we have provided. The curve lies in the spherical cell which we have given. And on the literature, we found that there is a systemic review which included 19 children with systemic sclerosis, which we found out the possible pathologies. So, conductive loss is mostly due to vasculitis and fibrosis of middle ear ossicles and involvement of auditory muscles, and which leads to disruption of osseous joints. And in case of neuro involvement, it is mainly because of vasculitis involvement of stria vascularis. So when there is compromise of stria vascularis, it will lead to sensory neural hearing loss. And whether the hearing complaint can be the presenting symptom of scleroderma, there are cases in which there was sudden SNHL, which is the first and foremost symptom. On further evaluation, it found out to be scleroderma. One important feature is that the children with progressive hearing loss and then children with sudden SNHL. In this, the children with sudden SNHL will have good prognosis in terms of recovery in hearing rather than progressive hearing loss. So, does hearing impairment has any correlation with disease severity? Yes. In case of systemic form of scleroderma, there is always universal involvement of hearing. In case of localized scleroderma, SNHL indicates that it's a severe form of disease, and in case of progressive hearing loss, the recovery from hearing loss will be very, very rare, and rehabilitation usually provided is hearing aids, and osteoplasty can be performed if there is only isolated osteolar discontinuity and cochlear implantations. And in case of localized scleroderma, it is very rare to have hearing loss. And in case of children, the child cannot say that he is having hearing loss. So it is often noticed by parents alone. So it is always recommended to do screening for hearing in case of children with case of scleroderma. So which will help in early rehabilitations. And in further course of treatment, we should avoid ototoxic drugs. And early diagnosis and initiation is the keystone of treatment. Thank you.
Thank you everyone for the excellent presentations, Dr. Abning, Dr. Japnoor and Dr. Ramneshwaran. So everything has already been discussed. I'll just quickly summarize it. It is basically an autoimmune disorder in which there is activation of T lymphocytes which accumulate in the target organ, resulting in production of localized inflammatory cytokines, progressive fibrosis. When it comes to the vascular injury, there is damage to the endothelial cells by the inflammatory mediators and progressive fibrosis, eventually resulting in fibrotic occlusion of the vessel wall. And wherever these vessel walls are getting occluded, we have these systemic manifestations. Certain genetic factors have already been discussed. In addition to those, HLA-DRB1 and HLA-DPB1 complexes have been shown to have increased risk of developing scleroderma. And there are certain environmental factors such as viral infections and toxins which have been shown to initiate an autoimmune response resulting in scleroderma. Again, scleroderma can have a systemic variant or a localized variant. Our patient had linear morphia, which is a subvariant of localized scleroderma, which is characterized by linear involvement. Among the linear morphia, we had this coup sabre variant, which basically involves the frontoparietal region. And our patient was a bilateral, had bilateral involvement, which is a very, very rare presentation among an already rare presentation, and only 10 cases are reported in the literature as of now. Again, our patient had a profound hearing loss and very significant and classical dermatological findings. I'll discuss the ocular spectrum a little more in detail. So, the ocular involvement is relatively rare. It ranges from about 2 to 3% in the systemic sclerosis variant and about 12 to 14% in the Encuda Sabre variant. The most common involvement is in the form of lid and adnexa involvement, which can result in ptosis. If the lacrimal sac is involved, it can result in significant dry eye. and ectropion and fornix shortening can result in exposure keratopathy. As the atrophy progresses, it can even involve the extraocular muscles, resulting in paralytic squint, restricted eye motility, and diplopia. Eventually, the eye can also undergo anophthalmos because of the atrophy of the orbital tissue. When it comes to sclera, patients have been documented to have scleritis, perforation secondary to scleromalacia, and prominent episcleral vessels. Anterior member has been shown to have anterior uveitis, anisocoria, sectoral iris atrophy, mydriasis, early cataract formation, and optic neuritis-like presentation. Coming to fundus findings, patients have been documented to have discrete ipsilateral pigmentary changes in the peripheral retina, which can show hyperfluorescence on FFA. Course-like exudative detachment has been reported in about 5 cases, and in one of the patients, despite repeated anti-VEGF injections, patient eventually lost vision. Again, there are 2 cases of optic neuritis-like presentation, a single case of pseudopapilledema or papillitis, and retinal telangiectasia has been reported in almost all cases where fundus findings have been documented. So our patient had significant ischemia, multiple NVs and TRD, which were as of now has been managed just with a laser of the ischemic retina. And if the TRD progresses, we might have to do a laser if surgery if required. Other CNS manifestations have already been discussed, so I'll quickly skip it. Again, to summarize, the disease can either be in active phase or the quiescent phase. In the active phase, the patient has to be treated with oral steroids and has to be kept on long-term immunosuppression. The most common immunosuppression that has been documented in literature is methotrexate, but so far it has been shown to have some promising results now. But see, it is primarily a dermatological disease, and the entire literature basically comes from dermatology. And when they have classified it as an active or an inactive disease, it is based solely on these dermatological findings, whether the lesions are increasing in size, whether the margins are bilacious or not. When we come across this patient who have these relatively rare ocular and ENT manifestations, should we consider these patients for immunosuppressants despite not really fulfilling the criteria for an active intervention? Just from the point of dermatology is the question that we have to answer. If the patient presents to you and you make sure that it is in the quiescent phase, then you will have to do serial photographs both for the skin lesions and the fundus photography. Actually, this patient was under treatment at a private hospital in Meerut for the past 3 years, had received had received a hearing aid also, and there a diagnosis of congenital skull anomaly was made. Quite honestly, when I saw the patient, I had no idea about this pathology. I also thought that this is some congenital cranial malformation. But I asked the mother, okay, these lesions must be there from the very beginning, and she was very vehemently saying, no, these are there for the last 3 years. I just asked her to show me some photos, and everybody carries a mobile phone, and she showed me these photos, which clearly showed that these lesions are relatively new. And this is when we started actually our journey of actually getting into the particular diagnosis. So I would request all of you to actually listen to the patient. Mothers are the best teachers, and subsequently this patient will require serial fundoscopy and clinical pictures to actually document any progression if it is there. So again, the question that I would like to raise here, of course the answer is probably just to observe. Should we start this patient on immunosuppressants right now, given the rare manifestations along with the dermatological things? In addition, there was raised eosinophils, which has been shown to be a marker of active inflammation in these diseases. Other inflammatory markers such as ESR and CRP were normal, but they have also shown to have some suggestion of an active disease in the future. Also, this patient was positive for rheumatoid factor, and these patients have been documented to have a higher incidence of rheumatoid arthritis if RF factor is positive in scleroderma. So, I mean, something that we'll have to work on. Probably a multidisciplinary approach and collaboration is required to answer this question. Just at the end, these are 2 articles by Zenin et al. And Fladelius et al. Published in British Journal of Ophthalmology and Eye respectively, and I would recommend these articles to all the residents here, at least for the ophthalmological findings. Thank you. Sir, like, would you recommend starting methotrexate or anything like this in this patient right now? The 10-year-old child, very aggressive from our point of view.
not for the eye, but the systemic features that was being seen is progressive. This is good thing.
So the scale lesions are not progressive for the past 6 months. That is why they have decided, the dermatology team has decided to simply observe it. So, ma'am, what would you say?
Apart from the systemic and the flexibility people are inclined for from our side it is mainly the rehabilitation part. And for now the child is responding to the hearing aid like what my resident had shown, that is known as the banana curve. So that's the aided audiometry. So after you've given the hearing aid, we do a testing again, and if the responses are within the banana curve, it means the child is getting benefit from the hearing aid. So we try and continue on a hearing aid. Once the responses are beneath the banana curve, that means the child probably would need some other form of a aid or an implantation. So then it's the proper implantation. So presently, I would say just continue with the hearing aid, but if in case it progresses further, we need to at least prime them and counsel them for a implantation.
So again, as I went through the literature, there is not even a single case report where any immunosuppression has been started by any other department apart from the dermatology. So that is something that probably needs an answer. Thank you for your time. Thank you for being a part of this CJR.
No, but two questions. What we have is try to gather how many patients we have seen so far, try to create a small rare diseases registry, and then I think we could probably put down some guidelines on how many we still I think divided into 3 different departments. So for us also it's the first time we're seeing a patient of this kind. And like you rightly said, if we have a screening guideline that's there, we would prevent them from going more concentrated or a severe stage of the disease. So I think that's one thing that we should take the lead now and try to put a preliminary registry together. And then from there try to create little guidelines if possible. Because we would get all the departments together with multi-system disease. That's one. The second thing is the unusualness of the involvement. When you say endothelial, when you say viral, so why is it so focal, why is it so linear? So again, one of the things that we should consider is developmentally, is it kind of targeting some kind of like the Bloskovic's lines that you have, I think in dermatology, that you will have involvement again and again, particular lines, some diseases involved in those lines. So here also it's very peculiar what we're seeing. So you need to see if there is something that's developmentally, there's some receptors that it's targeting. Endothelial cells is a very gross term. In the eye, it seems like it's a very global disease that you're seeing, but the rest of it is a little peculiar. So we need to go back here and try to see why it's targeting on the specific regions. That's very, something very interesting to know. And again, over here, since you're seeing a grossly ischemic situation, so it's obviously targeting the VEGF pathway, but whether the rest of the disease, the rest of the neural manifestations, the ocular manifestations, which receptor is it actually targeting? The ones that she showed, none of it actually mentioned the VEGF receptor pathway over there. So why is it that VEGF is not, we have not reviewed the literature deeply? So we have to look at why the VEGF receptors are actually getting targeted, or if there is some other lead that we can get from what she's just shown us, if there is some link between VEGF versus the other receptors that are there. So that's something that we should work on. I think all of you presented it very well. Thank you all so much. It's been a big learning for me and probably for all of us here at AIIMS. So I think any of you have any questions? I think
I would just like to add on to Sir's thing, like I don't know how much of such cases are seen by derma or the ophthalm. For me, I would say yes, it was one of the very rare cases. And as what my seniors used to say, that rare cases come in threes. Believe me, after your message that you have a linear morphia case, I had one more case, so I'm waiting for the third one in sequence. So yes, I see what mine knows. So unless I had known that there is something called linear morphia, because it was written Perry-Robertson syndrome. Yeah. So when the second case came to me with a Perry-Robertson syndrome, it was like some syndrome. And just when you Google it up and realize, oh, it's the same thing, just a different manifestation. So still just waiting for the third one to come. Like if it comes, I'll say.
Even I am waiting for the second case. So.
I'll send the second one to you.
Sure, ma'am. Thank you.